Thank you so much. And we continue with Nathan Denlinger from OSU. He's a hematologist.
Okay, autologous CAR T for the win. We'll see about that. Hi, my name is Nathan Denlinger. I'm a physician scientist and CAR T specialist at Ohio State, along with Dr. Rovin. My background is in lymphoma and allogeneic bone marrow transplant. I do commercial CAR T, novel CAR T clinical trials, but my real passion is cell therapy. So I'm a little disease agnostic in that sense. So they brought me here as one of those guys from the other side, the cell therapy side. So I'm excited to be here to discuss B cell targeting and immune-mediated renal disease. And then particularly, I'll be taking the side of off-the-shelf allogeneic CAR T. So what is allo CAR T? So this is important first, I think. Briefly, these are CAR T cells that are generated from healthy donors, or iPSC methods. These are renewable sources of cells that are being investigated. This is a pretty generic schema, but basically you build the CAR T, some target examples for BCMA, CD19, and then you knock out the T cell receptor, and you'll actually strictly deplete any cells that express the T cell receptor as well. And this essentially completely eradicates any risk of GVHD from these donor T cells. We now have hundreds of patients that have been treated with allo CAR Ts across a variety of different clinical trials for various malignancies. I haven't heard of any real reports of clinically significant GVHD that's been too intolerable. In most cases, all the ones that we've treated, there have not been GVHD. So you bank these cells, and then you have ready-to-thaw CAR T doses in packets in your cryobank. And so why are we researching allo CAR T? So this is the main reason, the life cycle of the CAR T. Already off the bat, you can see this is complicated. So I think you saw Dr. George's graph as well. There's a lot of points that you have to do a lot of different things. So for us, it's patient screening and eligibility. And here I put a little lightning bolt next to the pressure points. I think for autoimmune diseases, weaning immunosuppression is going to be the great difficulty. I've already heard from people just last night at the reception, they've heard of patients getting really sick while you tried to wean their immunosuppression. We run into the same problem in cancer. This was the first 10 years, the last 10 years, we've been trying to figure out how to get patients to CAR T successfully without having them sort of pass away or their disease take off in the interim. And I think it's the same thing with with CAR T for autoimmune as well. So you screen the patient, they're eligible. Now you have to wean immunosuppression. The FDA in the US mandates it, companies mandate it. You need to get some immune suppression off so that you can collect good T cells from the patient. That's auto CAR T. That means typically at least 2 weeks off, so 2 weeks or 5 half-lives is typical. And that's a risky time period for autoimmune flares. Different trials have different restrictions. Then you collect the cells, and typically it takes anywhere from 14 to 40 days to make the product. We do have trials looking at rapid manufacturing of auto CAR T, but most of the commercial, there's one commercial product that's 12 to 14 days. The other two main commercial products for lymphoma is about 28 to 40 days. So you then have to prevent flares of your autoimmune disease with bridging here. That's weaning again prior to CAR T infusion, and weaning again prior to CAR T infusion. However, with allo CAR T, you may be able to cut off a significant portion of this. So here, with an off-the-shelf CAR T, such as an allo CAR T product that was previously manufactured, you identify a patient, you wean the immunosuppression typically required just for that 2 weeks instead of repeated time periods, give your lymphodepleting chemotherapy, thaw your product, and then go. So what is it about allo CAR T that may be beneficial in autoimmune diseases versus auto? Okay, so why don't we just, so for example, simplified manufacturing and distribution. This can be centrally manufactured. Just imagine walls of a bank of cells in their cryobank that can be shipped. Every time we open an allo CAR T trial, we've opened a couple, they ship us like 50 bags of product right off the bat. We just have them in our own cell therapy cryobank ready to thaw whenever we need it. Significantly decreased costs. So you get healthy donors, you can generate huge amounts of it. If you use iPSCs, stem cells, you can derive unlimited amounts without even the need for a human interaction there. Off the shelf, you don't need to wait for manufacturing for a patient requiring treatment, so there's speed here. You can screen patient, wean, immunosuppression, LD chemo, and infuse. For For autoimmune disease, less time and complication required for immunosuppression weaning. I think that's the biggest thing. If you have sick patients, this would allow you to go without having to go back and forth between weaning immunosuppression, adding it back on, weaning, adding, weaning. So that for me, that was one of the biggest reasons why we wanted to do it in cancer. No need for bridging or anything. There's better availability potentially at non-tertiary academic centers. Once we optimize this process, we could ship these out to community centers too. They could thaw and do the same thing. The drawbacks. So he mentioned, Dr. George mentioned, these have not worked out well in cancer. So there is reduced efficacy of allo CAR T in cancer. There's less expansion, there's less persistence, you get host rejection. So imagine a big lymphoma mass, tumor microenvironment, immunosuppressive. You need massive quantities of CAR Ts to expand, to eradicate that tumor. They need to persist, they need to live in the bone marrow to keep eradicating any leukemia stem cells that come along. That's cancer, however. That's a lot different. So, with what we've seen, I think, in a lot of the early studies is that we're not seeing persistence of auto CAR T in autoimmune disease anyways. You get 3 months, you get B-cell aplasia for a few months, and then that's all that's required for this, quote, immune reset, perhaps. Decreased persistence also equals less immunosuppression with allo CAR T. There's no large tumor burden, so less expansion is likely adequate. You only need to get rid of the B cells and some of the B cells that are in the tissue, not big masses, not a bone marrow filled with leukemia. And then, of course, I think there's novel techniques coming along like CRISPR base editing as opposed to CRISPR-Cas9, which is going to reduce genotoxicity for multiple DNA edits. And then we'll have immune cloaking and things of that nature to help improve persistence. So in the end, for me, I think allo CAR T may be the future. So we'll see about that.